Morning, everyone. So I'll be talking about Wilson's disease and other causes of metabolic disorders of liver. Hemochromatosis, non-alcoholic fatty liver disease. So Wilson's disease is a familial disease which is mainly characterized by progressive lethal neurological dysfunction with liver cirrhosis and corneal abnormality. Mainly corneal abnormality, you see formation of corneal ring, cave rings. Okay, so it's a disorder of copper metabolism, and it is autosomal recessive. And the abnormal gene involved here is ATP7B. If it's ATP7A, it's known as Menkes disease. Okay, 7A is Menkes disease, and the ATP7B gene is involved. It is Wilson's disease. So, pathophysiology. Normal oral intake of copper is around 1.5 to 4 mg daily, and which is intestine. There is absorption in intestine, then which leads to plasma albumin binding, which is rapidly cleared, and in diseases like Menkes disease, which is an X chromosome abnormality. So this plasma albumin binding is altered, which leads to accumulation of the copper in kidney, leading to formation in the urine or in other tissues like brain, eye, and enzymes. Okay. So in the liver, so mainly Menkes disease affects other organs. It can affect the kidney, brain, eye, and enzymes. Whereas Wilson's disease, mainly it's a chromosome 13 abnormality, and there is deficiency of this protein known as apoceruloplasmin, which is a copper transport protein. So that's deficiency is there is deficiency of these apoceruloplasmin, which leads to accumulation of copper in the liver. Okay. So this post-ceruloplasmin is converted into ceruloplasmin with the help of an enzyme known as ferroxidase. So then ferritin is also converted into plasma transferrin. Okay. So this ceruloplasmin, here you see copper. So it has many and chaperones. These are chaperones: ATOX1, COX17, and CCS. So these three are known as chaperones, which help in the deliver the copper to the specific target sites, target proteins. So this is one target protein, ATP7B. Cytochrome oxidase, another target protein, and then you have ATP7B. So these are the target proteins. So mainly there is abnormality in these proteins, chaperones. So which see ATOX1 is mainly helps in the helps copper to reach the this target protein ATP7B. So COX17 helps in reaching cytochrome oxidase, whereas CCS helps in transfer to the protein copper zinc superoxide dismutase. Okay, so this is the function of these. So because there is abnormality in these chaperones, that will lead to failure of copper transport in the mitochondrium, that leads to accumulation. So this ATP7B with the help of COM-MD1 helps in the transport to the bile canal nuclei. Here, as I told, there is a deficiency of apoceruloplasmin, so that will lead to failure of the copper to go to the ceruloplasmin, conversion to ceruloplasmin, that will lead to accumulation of copper in the liver. So pathology, you see macronodular cirrhosis. There is steatosis, focal necrosis, glycogenated nuclei in the hepatocyte, which leads to copper deposited in the lysosomes. On electron microscopy, you see changes in the hepatocellular mitochondria, which is dilatation of the tips of the mitochristae. We call it as tennis racket. Okay, so this is one important electron microscope changes. Mainly you see copper, which is mainly deposited in the lysosomes, because there is cirrhosis, and it is very important is macronodular, never micronodular. Examples of macronodular, you have non-alcoholic fatty liver disease, alcoholic liver disease, all those are macronodular. Wilson's is macronodular. Clinical features: hepatic symptoms, patient will have jaundice. Sorry, just a minute. Okay, so I'm sorry. So hepatic symptoms, you have this jaundice, you have abdominal pain, and patient may develop cirrhosis of liver. Okay, so all those are the hepatic symptoms. Then you have neurological symptoms. Neurological symptoms, patient may have altered sensorium. You can have the patients, disorientation, flapping tremors. So those are the neurological signs. Hepatic encephalopathy. Psychiatric problems, patient may have depression, maniac symptoms. Ocular signs, most important is the corneal KF ring. So that's one important ocular sign. So diagnosis, mainly the ratio of alkaline phosphatase to total bilirubin is always less than 4. Okay, so that's how you diagnose Wilson's disease. The ratio of alkaline phosphatase to total bilirubin is always less than 4, and the ratio of ALT to AST is always greater than 2.2. Okay, so this is one important uh, uh, parameter for diagnosis of Wilson's disease. Alkaline phosphatase to total bilirubin less than 4, and ratio of ALT to AST greater than 2.2. So in these biochemical parameters, most important, ceruloplasmin, serum ceruloplasmin in Wilson's disease is always less. It's usually between 0 to 200. Normal is 200 to 350. Serum copper is reduced again here. It's around 190 to 640. It's normally 700 to 1520. So 24-hour urine copper is again increased, and liver copper, this is the gold standard test. If they ask you what is the gold standard test for Wilson's disease, it is the liver copper. So it's greater than 250. So that's micrograms per gram dry weight. Treatment, D-penicillamine, initially you give around 1 to 1.5 grams per day, or 20 mg per kg per day. So 24-hour urine copper is 200 to 500 micrograms, and estimated non-celluloplasmin bound copper is always less than 100. Okay, so you do a CBP, urine analysis, and skin examination as well. So to monitor that. Then you have trientine. This is the preferred one now. Trientine initial is 1 to 1.2 grams per day, and it is monitoring is same. You have to do CBP and iron studies. Zinc initially 50 milligrams elemental zinc thrice daily, and then you monitor the serum AST and ALT levels. So zinc with trientine is the preferred combination. So coming to hemochromatosis, it is an inherited disorder of iron hemostasis, mainly characterized by increased iron absorption, mainly that results in tissue iron deposition. It is always an autosomal recessive, and the gene involved is HFE gene in chromosome 6. Most common mutations you have, this is very important, C2A2Y, wherein the tyrosine to cysteine, and H63D from histidine to aspartate. Okay, so these are the most common mutations, C2A2Y, and if you find this positive, or you can straight away confirm it's hemochromatosis. Organs involved mainly liver, pancreas, endocrine glands, and as well as heart. So causes, you have primary and secondary. So primary hemochromatosis, hereditary hemochromatosis, you have congenital aceruloplasminemia, and then congenital atransferrinemia. Then secondary iron overload, mainly by giving parenteral iron, like repeated you give blood transfusions, iron loading anemias, so pyruvate kinase deficiencies, liver disease. All these are secondary iron overload conditions. So complex iron overload like juvenile hemochromatosis, neonatal hemochromatosis, alcohol liver disease, porphyrias, all these also can be the causes of hemochromatosis. So pathophysiology, the ferric ion is converted to ferrous in the presence of ferric reductase. This in the presence of transported DMT1. So that will lead to accumulation in the iron inside. This is the enterocyte. So here the ferrous form is converted to the ferric again in the presence of a transport of ferroportin and hephacetin. So this ferrin is again stored in the form of transferrin. Okay, so initially this because it's converted to ferrous form, because ferric is never absorbed in the intestine, so that's why it's converted to ferrous in the presence of ferric reductase. Ferrous form is again enters, and then it is converted into ferric in the presence of hemastine, and it's stored in as ferric form as transferrin. Okay, So in patients with hemochromatosis with these abnormalities with abnormal genes present, so there is this hepcidin is an important protein which helps in decrease in the iron absorption by the enterocytes and also decrease iron release by macrophages. Okay, but this is abnormal in patients with that, so that leads to hemochromatosis. Clinical features: patients have weakness, lethargy. Patient may have body pains, arthralgia, abdominal pain. They may have loss of libido, hepatosplenomegaly, diabetes mellitus, and they may have skin pigmentation due to increased iron deposition. So these are more common clinical features of hemochromatosis. So diagnosis: you do a serum iron level. Serum iron is usually elevated in patients. It's around 180 to 300. Transferrin saturation is also elevated. Normal is 20 to 45. So here it's 45 to 100. So ferritin in men is very much raised, 300 to 3000, and women also it's raised. So liver, you can do iron staining, so it will be strongly positive, 3 plus to 4 plus, and iron concentration is also very much increased. So these are the tests you're supposed to do: serum iron, transferrin saturation, ferritin. And the liver, you can do iron staining, iron concentration, and hepatic iron index. Okay. So this is also very important. I have already told HV mutation analysis. You do C2A2Y by C2A2Y. So these, if it's positive, most likely it is hemochromatosis. So liver histology, hemochromatosis, the stain which is used is pearl stain, which shows accumulating the iron within the hepatocytes, which is usually stained blue. Okay, so there is also accumulation of large fat. You see these fat globules in the hepatocytes. This is called as macrovascular steatosis. So iron is also accumulated in the cuff vessels as well. So diagnosis, first test you do is transferrin saturation. If that's normal, then automatically it is no further evaluation is because that has to be positive. So it has to be elevated. If it's elevated, first thing you do is genetic testing. You either do C2A2Y by HC3 or C2A2 by HC3. So if it's negative, then you evaluate for other causes of iron overload, like secondary iron causes. Liver biopsy, you can do it. If that's positive, then go for serum ferritin. Serum ferritin is greater than 1000. Then you go for liver biopsy. And serum ferritin less than 1000, and if the ALT, AST are normal, then you proceed with phlebotomy. Phlebotomy is the treatment of choice here. And if it is heterozygous, then go for liver biopsy. So treatment, you perform a phlebotomy of around 500 ml, that is 1 unit of whole blood. You do it weekly unless the hematocrit value drops below 37%. Then you check the transferrin saturation and ferritin levels at every 2 to 3 months interval to mainly monitor the response. And when the iron stores are depleted, that is in between 50 to 100, and transferrin saturation is below 50%, so you can maintain. Then you do maintenance phlebotomy of every 2 to 3 months of 1 unit. Initially do it at least thrice weekly, or twice weekly. Then you reduce it if the transferrin saturation drops and ferritin levels drops. Then you can go for once in every 2 to 3 months. Okay, your aim is always should be transferrin saturation be less than 50. Okay, and ferritin should be in between 50 and 100. That's your target. So coming to non-alcoholic fatty liver disease, it is the most common cause of chronic liver disease, mainly seen in the Western countries more when compared to the Asian countries. And it mainly represents the spectrum of liver disease encompassing three, most importantly, simple fatty liver disease, whereas you see steatosis and fat with inflammation, you call it as NASH, non-alcoholic steatohepatitis. Then cirrhosis, without any history of alcohol, it is very important. You have to rule out alcohol liver disease, and it is strongly associated with metabolic syndrome. Metabolic syndrome is nothing but you have hypertriglyceridemia, hypertension, diabetes, and obesity. Okay, so that's metabolic syndrome. Genetic factors. So you have these genes: positive PNPL3 and ApoC3, MTP, SOD2, TNF alpha, TGF beta. All these are strongly positive for alcoholic liver disease. So this is how a steatosis looks like. Steatosis mainly increase in the fatty acid influx, decrease fatty acid oxidation, increased fatty acid synthesis, decreased VLDL assembly, and also with insulin resistance that will lead to increase in the fat infiltration, mainly greater than 5%. So here there can usually there is no inflammation in fat steatosis, so there is just that fat accumulation. Okay, in NASH, non-alcoholic steatohepatitis, there is accumulation of inflammatory cells. So you can see here inflammatory cells as well, with ballooning and Mallory bodies as well. And in cirrhosis, ultimately there is increasing fibrosis, ultimately leading to cirrhosis. Okay, there is increasing fibrosis here, you see. Yeah, so there is TGF beta and stellate cell activation also. Okay, so this you see in cirrhosis. Clinical features, mostly it's asymptomatic. Patient may have fatigue, right upper quadrant pain, hepatomegaly, vitamin D deficiencies patient may have, DM, diabetes mellitus, obstructive sleep apnea, and hypothyroidism. So these are the clinical features. Mostly patients are asymptomatic, and patient may have fatigue and right upper quadrant pain also patient may have, hepatomegaly. Okay, and diagnosis, AST ALT should be less than 1. Okay, so in alcohol liver disease it's exactly opposite. Usually OT SGOT will be greater than SGPT. In alcohol liver disease, OT is more increased due to deficiency of an enzyme known as pyridoxal phosphate. So that's why SGOT is more than SGPT. Here it's exactly opposite. Imaging you can do for ultrasound is pretty good. Ultrasound is sensitive test, so look for any fatty liver or alcoholic hepatitis. CT-MRI can also be preferred. Liver biopsy is gold standard, but it is not usually preferred. Unless you don't get a diagnosis with imaging, you go for liver biopsy. Transient elastography is also done. Biomarker CK18 is the positive biomarker. So in patients with elevated serum aminotransfer, that is SGOT and SGPT, and along with hepato and or hepatomegaly, you have to, first thing is you have to rule out any excessive alcohol use and other forms of liver disease. Rule out other causes of cirrhosis of liver like Wilson's, hemochromatosis, all that you rule out. Then you do go for imaging. In imaging, if it's normal, then you have to go for biopsy. It shows fatty liver present, then you can do it to stage, or else you can go for elastography. Elastography is pretty good, you can avoid liver biopsy. So non-alcoholic fatty liver disease, 80% of the patients have only isolated fatty liver. Usually they don't have NASH. Less than 20% patients may have NASH. Okay, so NASH in 11% of the patients over 15 years, they're not treated, then they may develop cirrhosis of liver. And of them, 31% over 8 years may develop decompensated cirrhosis, and around 7% over 6 to 6.5 years may develop hepatocellular carcinoma. So histopathological features, most cases you see macrovascular steatosis. It could be diffuse or centrilobular steatosis, parenchymal inflammation with polymorphonuclear neutrophils, lymphocytes, and other mononuclear cells. Hepatocyte necrosis can be seen. Ballooning hepatocyte degeneration also can be seen. And you can see Mallory Denk bodies. This is typical of NASH. Glycogenated nuclei, lipogranulomas, and stainable hepatic iron. Okay, so most of the patients will have this macrovascular steatosis, parenchymal inflammation with inflammatory cells, polymorphonuclear neutrophils, lymphocytes, and other mononuclear cells. You can also see hepatocyte necrosis, and you can also see ballooning of the hepatocyte degeneration. So these are present in most of the patients. So biopsy, this is how a patient biopsy looks like in fatty liver. It is usually diffuse macrovascular steatosis without any significant inflammation or fibrosis. So this is macrovascular steatosis. You can see the fat lobules here. So without much inflammation. If there is inflammation, you call it as NASH. So this is NASH, non-alcoholic steatohepatitis. You see my diffuse inflammatory cells in between. So lobular inflammation is seen, and hepatocyte ballooning. You see these balloons, it's inflamed, and glycogenated nuclei also can be seen. So Mallory Denk bodies are also seen. So this is typical of NASH, non-alcoholic steatohepatitis. So treatment, most important is your diet. You have to restrict your calorie intake. So you have to target the weight loss at least 7 to 10%, and you reduce saturated fatty acids, most important. So avoid fructose from the diet, and reduce fatty acids and fructose from the diet has to be omitted. And omega-3 fatty acid supplementation can also be shown good results. And coffee also, this is recently shown that the regular coffee consumption around 2 to 3 cups, mainly it increases the basal metabolic rate, and it's shown good results for non-alcoholic fatty liver disease. Most important, calorie and regular exercise, regular activity to reduce um, um, the calories and burn calories. So moderate exercise at least 4 to 5 times, which is of 30 to 45 minutes each time is usually done. Then you have resistance training as well. So resistance training means you maybe you go to a gym and uh, take help of a trainer. So he will provide opposite resistance, though that he called resistance training. So that's also preferred. Mainly burns the chest fat and all, and abdominal core body workup. So that has to be at least 3 times weekly, and it also improves the insulin resistance and steatosis. Okay, so exercise is very important. Pharmacotherapy, vitamin E can be given 800 to 1000 international units daily. So pioglitazone can be given 30 to 40 45 milligrams daily. Pentoxifylline, if the patient has steatohepatitis, NASH, then you can go for pentoxifylline 400 mg thrice daily up to 2 to 3 weeks. Okay. Statins, if the patient has metabolic syndrome with dyslipidemia, statins are to be preferred. So bariatric surgery, you have many bariatric surgery. You can go for sleeve gastrectomy, liver transplantation, which is very important. It's the third most common indication for patients with say any patients with, it's the third most common indication. It's more commonly seen in the Western countries. Now it's seen in the Asians also. Okay. Thank you.